This has been a very exciting time for the treatment of CLL. There's a lot of new agents available, and the importance of these agents is that Ibrutinib, Idelalisib, and now Venetoclax, what they all have in common is they all are highly effective in what we used to define as an unmet need for CLL, those patients who did very poorly with conventional chemotherapy. CLL as a disease was always characterized by a response to therapy. Until recently, chemo-immunotherapy was our standard of care. Patients would become resistant to that therapy, and then the duration of each response thereafter would be shorter and shorter as the patients became resistant. A major mechanism whereby that resistance arose was by the cells developing abnormalities in the p53 pathway, which is essential for chemotherapy to work, so that patients were becoming less and less sensitive to chemotherapy until there were then no therapies available. So the unmet need that we had was for those patients, that minority of patients who present with abnormalities in the p53 pathway, or for those who have a very short duration to therapies like chemoimmunotherapy. And the kind of time frame that we considered refractory was those patients who relapsed within 2 years of that therapy. Those patients had dismal prognosis until very recently. So what's changed is the availability of the class of drugs, the BCR inhibitors, both Ibrutinib and Idelalisib, which is used in combination with Rituximab, but also now Venetoclax. What all of these agents have in common is an ability to show very high responses in those patients who are refractory to chemotherapy, and very importantly, also to show responses in those patients who have abnormalities in the p53 pathway. So unlike the previous chemotherapy agents, these agents are equally effective in those patients with and without p53. That meant that they have filled the gap of what was previously our unmet need. Now that we have had these therapies available, our unmet need became those groups of patients who either failed Ibrutinib or Idelalisib Rituximab, or became intolerant to it, or couldn't have it in the first place. For that group of patients, we've now also got to our armamentarium the addition of Venetoclax. And clearly what that's meant is that what we've seen is that whereas chemoimmunotherapy remains the treatment of choice for patients frontline unless they have a p53 abnormality, for those patients who fail, we're going pretty much on next line into usually Ibrutinib. And what we're now suggesting is that for those patients who either fail or are intolerant to Ibrutinib, Venetoclax becomes a very attractive next line of therapy. The natural history of that is that with each of these agents, once approved, they're moving earlier into the lines of therapy because they just look so much more effective than the therapies that we had before.